Good afternoon, everyone, and welcome to today's program. It's titled Revenue Cycle Management Metrics and the Health of Your Organization. I'm Dennis Grantham, Editor-in-Chief of Behavioral Healthcare magazine. Today's program is sponsored by the Echo Group. Many thanks, of course, to our sponsor and to all of you in the audience for giving us your time and attention today. Before we get started, let me just run through a few housekeeping details. Each window on your screen can be moved by clicking and dragging, or you can enlarge it or minimize it by clicking the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. If you can't see this area right now, simply click the red Q&A button to make it appear. To download a copy of today's slides or other materials related to today's topic, please click the link in the Resources area in the upper right of your screen. If you have any technical issues during the program, please click the yellow Help button, and you'll get help troubleshooting the issue. With those remarks aside, let me introduce our speakers, Joe Viget, Suki Norris, and Amber Cooper. Joe joined Echo in 1999 with a varied behavioral health background, including experience in case management, managing residential systems and community-based treatment teams, and working with diverse populations. Joe is currently Vice President of Business Development for the Echo Group. Suki Norris, Echo's Senior Knowledge Engineer, has 25 years of experience in healthcare, including work with healthcare law, managed care, and behavioral health. She has been with the Echo Group for 15 years. She has extensive experience with HIPAA transactions and reporting and billing rules specific to California. She's managed a range of large projects, including managed care implementations and countywide implementations. Suki received her BA in Economics from Mills College and a JD from Golden State University. Amber Cooper, our third speaker, is Echo Group's Manager of Revenue Cycle Management Services. In this role, she oversees the day-to-day operations of the Echo Group's Revenue Cycle Management Service, where Echo staff perform claim submission and remittance to maximize billing revenue for customers. Amber has over a decade of experience in medical office operations and client billing in medical office, dental office, and behavioral health environments. Thanks to all of you again for taking time to listen to us and to our sponsor today. With that, let me turn the audience over to our speakers.
Good afternoon, everybody. This is Joe Viget. It's great to have you together today for this topic. As Dennis said, I'm the Vice President of Business Development for the Echo Group. And for those who aren't familiar with us, the Echo Group is a leading provider of behavioral health revenue cycle management services and software for electronic health records, as well as billing software and managed care products. We were founded in 1982, and we have 40 customers in 40 states representing organizations across the continuum of care in behavioral health and payer organizations. I'm excited about today's webinar because I think we're digging into something that's a little different than what we typically see on conference and web seminar agendas. We're going to take a look at fiscal data, which isn't all that uncommon, but we're not going to do it just for the sake of managing the bottom line. Our presenters today are going to elevate that topic and see if they can offer some ideas about how you can take a more global look at your operational and fiscal health by examining merged data sets of both fiscal information, clinical information, and service data. And I think we're going to find that there maybe are some other ways we can look at how to make some management decisions as we move forward here with some of this information. As Dennis was so nice to orient us, Suki and Amber have extensive experience on these topics and spend a lot of time working with actual customer scenarios and actual customer data. And many of the slides and charts you're going to see today come from those experiences. So with that, I'm going to turn it over to Suki, and we'll begin the content of our presentation today. Thanks for being with us.
Thank you all. So 20 years ago, data was one-dimensional. We could, funders wanted to know about our caseload and kind of what kind of information about our clients that we could provide. Maybe we would ask questions or poll clinicians, perhaps pull data into an Excel spreadsheet and count to provide the kind of requested data that was the data that was being requested. Today we need this data, but to support the overall picture of our agency and health of our agency, and when the electronic health systems of today, and with the electronic health systems of today, data is much easier to view and easier to report on. This is a simple graph of just my caseload as it relates to gender. This next graph looks at the legal status. And maybe this data is needed to know to get some ideas of who are we serving. Perhaps we're asking questions like, do we have programs that are available to support the kinds of the breakdown of the legal status that we see? If we see that we have many people that are just getting out of jail, do we have programs that we can provide to our clients that really deal with that population in that transition? The living situation in a caseload, again, maybe it's a one-dimensional view of our data, but perhaps you look at the percentage of homeless. While it's not a large percentage, we can ask the question, do we have services, are we providing services to our population, to our caseload, to deal with these kinds of services, to deal with this kind of this issue within our population? Do we have services that are designed to help the homeless with the kind of issues that homeless folks, that homeless may be presented with? And finally, you see employment status of caseload. And today, even 20 years ago, looking at this kind of data was important, because if we saw changes in our caseload, then maybe we would also need to make changes in our agency to provide services that address particular issues, perhaps the unemployed, maybe the unemployed not seeking work. Again, by having these kinds of graphs, as rudimentary as they might be, it's an easy visual look into what does our caseload look like, and based on what we know about our agency, are we really addressing the needs of that group? But data was one-dimensional at this point. It was collected, as I said, in a fairly manual way, perhaps again by polling folks, maybe looking at people who came into the system. But very few people could collect it electronically or did collect it electronically. But that was going to change, because what was going on in the industry is that more people were getting electronic records, and at least records that would capture service information. And still we had data that was somewhat, that didn't go between clinical and fiscal in a way that you could make uniform kinds of decisions. But here, as time progressed, we began to be able to collect the cost data that you see in front of you. This data now broken out by diagnosis group. So what was once a single sort of looking at data in a very singular form, now we can compare and contrast data. We can look at data as in sort of a multivariate way, where we're really looking at how certain elements may affect how we look at our populations. What you see in front of you is cost by diagnosis group. And here I can see exactly kind of who's receiving services based on who's receiving services, or the diagnosis of who's receiving services. Am I actually providing the programs and making available the services necessary to kind of meet that need? As an example, you might see this large portion here, which is which would show the group of psychosis. So you see that the majority, the greatest issue diagnostic group-wise that we are treating in our agency is psychosis. Well, we know the mix of the services we provide, we know the programs we provide. And now we can ask that question, are we really meeting those needs? We've gone beyond just looking at one-dimensional, looking what our caseload is, but now we're looking at what do we need to service within that caseload. You can look at this same data by license type. So we know that the majority of issues that we're facing in the majority diagnosis group is psychosis, but we look at this data and we see that that really 2/3 of the data of the services being provided within the agency are being provided by licensed clinical staff and unlicensed staff. And in that view, and with that kind of breakdown, are we really providing the services? Do we think that we're providing the services? Are we making available the providers necessary to address the kinds of issues that we now know our agency is seeing? Again, what we've done is we've progressed beyond that single variant to start looking at how data compares and contrasts so that we'll know we can ask more questions and get more information about how we're doing and what we're doing. This data can also be seen when we look at the numbers of services we're providing. As we look at the numbers of services, we think, well, the numbers should match to the dollar amount, and many times they do. But also it gives us still a better breakdown, a better idea of what our agency is doing, and ultimately it will lead to our understanding really the health of the agency. But right now what we've learned is kind of the activity of the agency. How does that data show, and how does that data reflect what we know from a more visual aspect, because we are in the agency on a day-to-day basis? Does this really match what we expect to see? And if it doesn't, we're still in a place where we're still looking about 10 years ago, where perhaps we don't have systems that are going to give us the detail of data we're looking for, but we are able to at least now see data as it interrelates, to start getting better questions, to dig a little deeper, to understand a little more about what we're doing and how we're doing. You can also see the same idea when you look at numbers of services by license type. Now I've taken it that same step. Now this should be, and it in fact is very similar to what we see with respect to the costs. We're going to see that the bulk of services, just as the bulk of dollars paid, are provided by unlicensed and licensed staff. But interestingly enough, is that there may be an indication that the services may not. This is where you might look at how the services and the cost data relate, because what you're really going to look at now, what you're looking at now, is still from the clinical side. All we're asking questions now is about the clinical health of the agency. What are we doing? How are we doing it? And what's it going to cost us to do it? And then about 5 years ago, a major shift came along, and that was when people started sending in claims electronically as an 837, and equally importantly, receiving payment data back electronically in an 835. We began to be able to look at our denials. We began to look at, we knew how much our services cost, we knew how many services we were doing, but until we started really being able to get this information electronically, which is really just in the last 5 or so years, we weren't able to compare our denials to what we got paid. And what you see in this slide is, this isn't what we want. This is not going to support the health of the agency, because what this slide shows is of all the dollars, essentially 25 cents out of every dollar is being denied. That's not the kind of denial rate that's going to keep our ability to expand and support the programs that we have going right now. And equally importantly, it now begins to help us come back around to those services and the services and dollars to ensure that we can continue to provide services that meet what we know to be the diagnostic mix of our agency, to meet the problems that we can get because we can see the different groups in the demographic data. But if we can't manage our revenue and our denials, then we're not going to be able to support that. And with that, I'm going to talk about sort of how in the last 5 years we've really developed the concept of revenue cycle management. I'm going to pass the mic on to Amber.
Hi, and thank you for having me today. On this slide, we're going to talk about denials and denial management and how that data can be analyzed to sort of become something meaningful and useful. Denial management performance is not just about recovering claims that have already received a denial. It's about using the information learned from those denials to improve processes and avoid issues in the future. It's all about creating a culture of denial avoidance. Sorry. The data that is derived from those denials is equally as important. Facilities and agencies used to view denials as simply lost money or money that could potentially be collected with additional effort. But it's much more than that. The denials help identify areas of broken processes throughout the facility and or agency. On this particular slide, you can see the number of denied claims and their associated denial reasons. For services denied related to incorrect demographic information, those are typically due to fractured processes at the point of registration. For example, expenses incurred prior to coverage, patient cannot be identified as our insured, claim cannot not covered by the payer contractor, or care may be covered by another payer per coordination of benefits, etc. Other denials may have to do with credentialing, provider not certified, eligible to be paid for service procedure, or rendering provider not eligible to perform service billed. So you can see there's additional value associated with denials that you run into in your facility. On the next slide, you can see the monetary value associated with each of these denials. This paints a more fiscal picture of the denial items we discussed, and this sort of analysis would allow your facility or agency to sort of visualize where the bleeding is as far as your money is concerned. Resources could then be allocated to review those hard-hitting denials to recapture as much money as possible, and of course improve processes to ensure these denials are minimally experienced in the future. This sort of analysis is important as well because it allows for those in control of operations to more accurately prepare budgeting. Accurate budgets assist in maximizing a healthy cash flow, which is both essential and imperative in today's economy, where every penny matters. Here we have denials that are broken down by denial reason, as they previously were. But this time the information is further drilled down by the type of providers rendering the services. Jeff, can you go ahead and enhance the slide, please? Okay, my apologies. These are broken down by denial reason as they previously were, but this time the information is further drilled down to the type of providers rendering the services. While the type of provider may not always necessarily be associated with why the denial occurs, it adds yet another facet of multi-dimension to the way we analyze the data. When you see denials associated with a type of provider who should not be providing certain services, for example, you could start to look at your provider service mix and start to think about where some changes could be made. Okay, I have X provider performing services that never get paid, whereas if Y provider were rendering them, they would be. Is there a training opportunity for providers here? Is everyone who can be credentialed with certain pay sources credentialed as they should be? And I'm going to hand you back over to Suki now. Thank you so much.
As we start to look at this data, we begin to really see the value of the multi-axis of being able to look at data across multiple areas. We started by looking at just that data that was maybe a caseload breakdown. We then began to look at data that was related to service costs, but we really had no reality in it because the service cost had no relationship to whether or not we were going to get paid for those services. And we were still dealing with service in sort of with data in kind of a siloed mechanism, in silos. But then we began to look at that data across. We began to break those silos down, not throw data over a wall as much as collaborate in our look at the data, so that data was being the data was being presented in a way to allow the clinical staff and fiscal staff to join in a conversation about how do we resolve the kinds of issues that we're seeing. And equally importantly, not just do we look at what the impact is on the billing that we're doing, but what is the impact on, we always have to ask not just are we going to get reimbursed for the services, but perhaps we're not. But as you see in the slide with the services denied, as you see in the slide that, as you see in the slide the slide in front of you now, what you're seeing is denials by license. But what you're also seeing is perhaps areas where free services aren't bad services. The reality of our business may be that we have a significant number of nurses who are providing services that are not reimbursable because that's the role of nurses in our organization. And as we ask those questions and we get those answers, we look for data to be supportive of that. We look for data to not to confirm that analysis, but also to drive that analysis. So the real value of what you're seeing then is that it does more than just inform. It should enlighten, and it should provide you the ability to make the decisions that you've been making for the entire scope of the 20 years, but finally with the kind of data that one needs to make these decisions, data that allows you to make decisions that are informed based on what you know about your client base, what you know about the services you provide, what you know about the diagnostic mix of your client base, and then what you know of the license types that you have available to provide those services. And if you could, we're going to change the slide. And again, what you're seeing here is the same idea, and I know Amber spoke of it too, but here you get an even better idea of the kinds of services that we're not able to provide, we're not getting reimbursed for. And so questions can and should arise as to are these, when you see the diagnoses, the denials by diagnosis group, you ask yourself, are we doing accurate diagnosing? Because do the clinical policies and procedures need to better reflect the client base we're serving? And if it accurately reflects, are we actually identifying the services that the payers at least would allow for reimbursement for these diagnoses? And those are the questions that you can now begin to address as you look at this kind of data. As you look at this kind of data and ask these kinds of questions and have this kind of information available to you. And again, this is information that even 5 years ago was hard to come by because it is the regulatory changes and the push to electronic records that have provided this kind of the ability to look at data in this way and to analyze data in this way. So when you look at traditional data models have looked at process measures like billed versus received. What we're proposing is an analysis that compares perhaps poor or inadequate billing results, performance, with the realities of the service mix and population demographics. 20 years ago, data reporting was manual. Today, with products like Rapid Insight, products that allow you to easily access your data, easily report on your data, we've moved as an industry that from a place where we worried about and we were challenged by how to report, and now we can finally focus on what to report. We can finally focus on, now that we have this data, how do we use this data without a wall between finance and clinical? How can we use this data jointly to ensure a maximum return on our revenue, as well as an appropriate diagnostic mix and service mix to meet the demographic and diagnostic needs of our population? And really, that's what this new era in data analysis and in revenue cycle management is providing all of the agencies across the country, because finally we can ask those questions, we can get at our data, and we can ask questions, and we can expect and will in fact get answers that will help not just understanding today, but help in our planning for tomorrow.
Okay. With that, Suki, thank you very much, Joe, Suki, and Amber, for kicking off the presentation. Now we can move to questions, and I encourage everyone in the audience to use the question feature and submit. There was a lot of information in there, so one of the things I hope to do is talk it through with you and review some of the key points. But let me start by asking, where is all of this data coming from, speakers?
Well, this data was pulled from a series of customer databases, but it's actual production database, production data from various customers over the course of. Some of the data really spans 2 or 3 years.
How do you go about calculating some of these costs? Building up these data fields or these analytical graphs and stuff that you can actually dig into this data and go through it. Certainly there must be some key factors, and maybe you could discuss the area involved, whether it's clinical or financial, and then look at the typical elements that are going into the, for example, the data charts and graphs that you're showing.
Well, we look at data across. What we try and do is just as I've discussed, with the concept of saying that data is no longer fiscal or clinical, but more of a continuum of data. We look at data in that continuum. So that all fiscal data, as we look at it, is tied as part of that analysis back to the clinical realities of those services that are provided. And we really look at it as simple as every claim that's submitted and every denial that's received or paid, or a claim line that's paid, is really representative of a service. Every service that is claimed or denied is representative of a clinician interacting with a client. And behind that is a diagnosis as well as some other information. So we look at that, we really are driven by the claim and then link that clinical data to it so that we recommend that we never look at data completely void of the clinical side or the fiscal side, and really create this and use in data analysis the same thing that's happening in sort of products today, this kind of integrated concept of what an electronic record is. No record is just clinical or just billing anymore, so no data analysis can be just clinical or just billing.
Mm-hmm. So what's going on in the organization then is that you have, at one time you would have had financial people looking at one set of data and clinical folks looking at another, and now just everybody's looking at the same thing, or do you provide them different views or something like that? Can you perhaps provide an example about that?
We strongly recommend that people look at both sides. I think Amber would agree. Sometimes it's harder to get folks to look at denial codes and denial reasons than it is to look at a diagnostic mix. So what we try and do is take the denial codes. Unlike you, we kept them as true denial codes in this conversation because we wanted the revenue people in the room to recognize them and to understand this data and where this data was coming from. But if you think about a group of executives who are going through, or a group of leadership within an agency, then what we would do is try and create denial reasons that really don't look like those ANSI standard reasons, but are more narrative reasons that can be easily summarized and grouped to make it seem for folks who are not fiscal less of a fiscal discussion and more of an agency-wide discussion, understanding that there will always be a revenue cycle management group responsible for really putting blinders on and looking at that at the revenue side to ensure that there's no systemic issues that are causing claims to be denied, et cetera.
I was intrigued by that. So you work from the diagnostic mix into the standard insurance reasons. So you're essentially translating what you're finding here. Are there any of the slides we might go back and look at to show how that evolves? Because you kind of went through that fairly quickly. How you build in the multi-dimensions of the data that you're working on.
So if you look at these, let me go back to this one. So if we look at this slide as an example, we're going to see, actually let me go back one more, sorry about that.
Oh, that's fine.
So excited about showing slides, I just keep moving. If you look at this slide that is coming out now, you're going to see a cost by license type, let's say. So I'm going to be looking at cost data here. And as I look at this data, what I want to do is create an extension of this data that takes us all the way to the slides that include denials so that you can see the life cycle of that service in essence. So I will start here, and this may be the first thing that some clinicians see. This may even be information that clinicians have about their caseload in some agencies, at least number of services, maybe the dollar of services. And then we start to break that down. So what we've done is, as you see the license types and the diagnostic groups tied to just straight dollars, we then bring in the reports that have these same breakdowns, the same breakdowns by diagnostic groups, the same breakdown by license type, and then start bringing in what those denials are. It's a very careful and it's always, you want it to be for people to use data, you don't want data to be accusatory. You want data to be informative. So it's oftentimes good. That's why we always look at things like these services weren't reimbursed, but it is conceivable we never expected for them to be reimbursed because they are a set of safety net services we provide or free services we provide to meet the community needs. So what we're trying to do is, while we have this data, to take ways to provide it in a non-accusatory, non-inflammatory way in order to support everybody kind of seeing what the trends in the data are.
Okay. Okay. We're getting in a mix of questions now. Some are sort of specific to, it sounds like specific to your particular brand of software. I'm going to hold off on those just a little bit, knowing that certainly you can answer those, and move to a couple of the more general questions. What is the ideal billing team in terms of personnel structure for sending claims through the process of working through denials, including the relationship of IT services or those that maintain third-party software? Is that question clear enough for you, or should we walk through it again? Ideal billing team, personnel structure for sending claims through the process of working through denials, including the relationship of third-party IT services.
Hi, this is Amber. I think that the ideal billing team and personnel structure for sending claims through to working denials, including the relationship of IT services, would, you're going to want to have a mix of people with a good knowledge base, of course, people who understand how billing works, rules and regulations for government payers, and you want to be able to have somebody from a technical standpoint available, certainly for issues with 837 submissions. There are denials associated with that. 837s are the electronic versions of claim file submissions. You want to have people who can sort of understand the background techie talk of working through those, so you have somebody to relay some of your denial issues to and to help you work through that.
Okay. So you've got a sense of that. Another question, are these reports generally available in your system or another EHR system, or do you have to work through a third package like Crystal or SQL?
Well, I think the first question is that the data the first answer is that data is available in all systems that actually transact work electronically. And from that point, I know one of the ways we deal with it is by creating extracts, so that the same data that I might work with, we'll create extracts so our clients, our customers can work with that data. In some instances, you can use Crystal reports. You can use Microsoft products. You can use products such as products where reporting is really made easy, sort of a point and click kind of something like Rapid Insight. But it's driven by the ability to get that data easily from the system. And the way we do that mostly is by creating extracts. And again, the data that I've worked with in this was based on extracts that we can pull directly from the application.
Could you describe what might be the characteristics of a particular extract and what it might do, just so people can better picture?
Oh, sure. We have extracts. We have an extract that will pull out the service data, the service-related data. And what that will do is it will de-identify the client, but pull out a client data. It will pull out client demographics. It will pull out the service, the provider that provided the service, and then sort of where and what the service was, where it was provided, however the entity is broken down, however one defines the location and the kind of program that's received. And then we have we have an extract that will bring out that billing, the claims and payment data, so that you can see. And there are linkages between those two pieces of data by in every system there's going to be linkages, but there are linkages by particular IDs, so we can easily link up that database in Excel or in a reporting tool. Because this data, so it's really done by those kinds of defined extracts again, and those extracts really do follow the kind of analysis that I did, and they support everything from those demographic slides to the more complicated denials and dollar amounts, denials by license type or by diagnostic mix.
Okay. again, I'd remind our audience that to use the question button, or if you want to go through some of these other areas of the discussion here. There's a question here. Well, where do I pull this information now with our current version of the? Is there a particular extract function or feature that a user can use, or is this something that needs to be done by the provider, the company that's offering the software?
Hi, Dennis. This is Joe. The Suki data that we showed today is a combination of, for our system, I can't speak to everybody's system. For our system, is a combination of reports that are standard in the menu using the extract functionality Suki mentioned, which allows our customers to take kind of a more ad hoc view at things and be a little more creative about how they're looking at data. And that's some of the work we did in preparation here. Every vendor is going to have a slightly different circumstance that way. So.
Mm-hmm. Okay. And in summary, I know you've put a lot of stuff together. Are there particular fields that, literally fields of data that you want to go through and say, well, for services, I want to look at XYZ. For costs, I want to look at XYZ. For claims, I want to look at XYZ. Is there any kind of a short list or rules of thumb for the sorts of specific items of data that you'd want to look for or list out if people were attempting to think this through and replicate it on their end?
Yes, I think that what you want, I think you want to look at the demographic items that are important for your agency. And that's the first piece. So I want to understand the clients that I'm reporting on by the characteristics that are important. I've worked with agencies that deal with examples I've talked about today with homeless programs and a large percentage. So I want to make sure I don't want to do anything where the reporting that I'm going to take out is going to lose those major characteristics of how I do business, or I'm grant funded for certain things. And I want to make sure whenever I start this reporting to include those items so that I can create subsets of these reports for the purposes of doing my grant funding reporting at the same time, in essence. Mm-hmm. So we've got first the client and the client characteristics. And you should always start with not just having those client characteristics, but as I started today, with defining what they are. That could be easily the front of a report. The next piece is, and today we use diagnostic mix, we used license type, but you want to define those services by you want to identify the key elements of how your system defines an activity or a service. What the service is, who provided it, and where it was provided. Those are three. Every system has that. Every system does it a little differently. But systems will have those key elements because those elements are going to be part of what you're needing, what this report is going to show. An example, if I'm going to provide services for a homeless population, probably I may want to go out to centers other than my agency where homeless shelters or other locations. Well, you want to make sure that in the data you're pulling, you can actually indicate and show how the data elements you're pulling relate absolutely to the demographic information that you see as important. And then, I think if I'm Amber, I'll say most importantly. If I'm me, I'll say of equal importance. You want to make sure that you have a good understanding of your denial codes. It's really easy to understand when a claim is paid. You don't really have to look at any extra codes. There's just a very happy smile next to a record in your system. But denials need to be coded, and they need to be coded not in a narrative, but in a discrete data element. The 835 electronic submissions make that easy because they tell you what the denial reasons are. They have very specific codes, and even if you don't have that, even if it's a paper claim and you have denials, the reality is those denials that come even on paper EOBs can translate to a data element type denial code or reason. And when you do that, then you're going to have, and that will be important because whether you use all those data, whether all those data points are going to be used in every analysis is an open question. But if you have that data and somebody says to you, and somebody will always say to you, what's my denial, what is my denial percentage? They'll always put it that way too. What is my denial percentage? You will be able to, with a click of a couple of buttons, be able to give that answer. And one of the real values in revenue cycle management in the work that I do and others is not can I get data, but how quickly can I answer the question that's being asked of me. If somebody asks me what my denial percentage of denials is, and I don't get back to them for a week, a lot of things get assumed at that point. So it's really important then as you build this data set, to ensure that you have the ability to include in this data set sort of what your denials, what your payments are, and be able to group by those and report on those.
So what you're really doing is exploring a whole kind of strategy for looking at your data, examining it, and kind of stacking it up against each other so that it reflects different things. How down the line further, once one assembles, for example, this data, can you explore maybe an example or a scenario in which a supervisor or manager might look at some codes that appear to be unrelated for denials, but then realize it's really coming down to a potentially or particular interaction within a group or with an individual or something that's following it up. In other words, tell us a little bit about how a manager or somebody might translate what's going on in those denial codes into something that his team or her team can work with and improve on.
Okay.
Well, Dennis, one of the things that was interesting to me when we looked at putting the slides together and started talking to Suki about what we were pursuing, and I'm just trying to make sure I have the right slide to speak to here. If you look at the denial by license type and amounts, it's a color-coded stacked bar graph. So when you look at that, you can see the different types of staff that are contributing to a denial rate. And just very quickly, you see there's a fair amount of orange on that screen. And to me, this is what really drove home the presentation as the least financial person here, more as a moderator, but that's done a lot of consulting with our customers in other areas. But there is a lot of questions for a management team, I think, if they're astute enough to catch them. So, for example, Suki mentioned earlier the idea of free care. Is the fact that the nursing staff, that's what the orange represents, is generating a lot of denials in your organization an acceptable thing? Is that because the nursing staff does a lot of free care, because the SPMI population is often underserved medically, and so they're filling in gaps? And is that part of your organization's mission or not? And is that a good thing or not? And if it isn't a good thing, then, of course, how do you manage that? How do you change that? How do you address that issue? How do you change the behavior? And is it a personnel-driven issue, or is it a systemic issue? Is it something that case managers can pick up the slack to get those clients to a real doctor instead of having the nurse practitioner fill in? And maybe that is what's causing the problem. Maybe the case managers are bringing their clients to the nurse practitioner and saying, gee, Bob has a headache. Can you help him out? This was the rich thing to me, is how comparing these metrics together created a deeper insight into what the denial story was. It wasn't just the speeds and feeds of the billing organization. It was really the functioning of the whole organization.
Now, Joe, I noticed there's also a lot of a dark blue on that. I can't quite read which group that is. What clinician, some kind of Medicare, or I think it's the first group down at the bottom there. Can you elaborate on that, or is that?
Let's take a quick look here. Yeah, that's clinical staff, therapy staff.
what sort of mistakes might they be making that might lead to a denial, or what might be going on there?
Well, I think that it's going to be potentially one of two things. If the when you see the charge exceeds, and I'm stepping on Amber a little bit, when you see that the charge exceeds the allowable, it could mean that that the coding isn't correct, that the service that's being coded by the clinicians isn't exactly what the agency would expect it to be. The other thing it could be is that the agency might, in fact, have charges that knowingly exceed their Medicaid reimbursable rate, and that's just something that they would decide within their setup. But I'm going to say that if that were the case, then we would manage reporting differently, because if that's the case, we wouldn't; those would be really not reasonable to be part of that denial rate.
Yeah, the other interesting thing about that is if clinicians are billing out, if a therapy hour is being billed out beyond the Medicaid rate because the agency feels strongly about kind of billing their usual and customary and generating an underpayment, and then tracking that underpayment against their usual and customary. As Suki said, the reporting has to change. But again, does this tie out to that financial reporting? Does it tie out to the fact that you're taking a contractual adjustment on a certain type of claim? And comparing these two data sets, I think, help you understand that it balances and makes sense.
Yeah. And now, if you were taking a contractual adjustment on that, you might want to get rid of some of that information in that blue line at the top, right? Because your financial people would know why that's appearing, even though maybe it shouldn't be there, right? Otherwise, there was a related question here briefly. Why do charges exceed allowable amounts typically? And since on your graph it appears this is a significant loss, what can be done, or a significant issue, what can be done about that? So I think they were, again, reacting to that particular line.
Yeah, that could be due to a few reasons. Charges can exceed allowable because, perhaps rate tables or expected charges within your own system haven't been updated in a while. It's really important to stay on top of what particular insurance payers allow for you to charge, where they will make payment. And this particular graph that you're looking at, while a large portion of those particular denials are associated with the clinicians, it doesn't necessarily mean that those denials are related to that clinician or to it being a clinician, but it's just another dimension added for you to sort of break down what denials you're looking at and how they affect your agency and your organization.
Okay. Well, I certainly got an education today. I thank everyone for their questions and thank all of our speakers for a very informative presentation today. Thanks go to Joe Viget, Suki Norris, and Amber Cooper. Certainly, we also want to thank our sponsor, the Echo Group, for making today's program possible. Finally, many thanks to all of you in our audience for participating today. We hope you'll join us in the future for another behavioral health care webinar. With that, have a great afternoon. That concludes the presentation.